Thank you for the kind introduction, and I feel honored to be part of this event, and I'm very grateful to the organizers for inviting me. To begin with, the place I work is called Dharan city, which is situated in the eastern part of Nepal. It's the major city, and it is located in the foothills and serve as a trade point between the plain regions and the hill regions. And just about 30 minutes ride from the major city, you have a cool and rejuvenating hill station called Vedita. And the hospital currently I've been employed is a tertiary care center, which was been established in 1993, and it provides wide spectrum of healthcare facilities. And if we see the stats from the last year, there were more than 10K deliveries been conducted in our hospital, and of which there were approximately 29% of CS sections. There were 201 patients who were admitted in maternal intensive care unit, 10 deaths, 4 left against medical advice, and overall there were approximately 15 maternal deaths. Now, the stats of this hospital may not reflect the exact scenario all over the country. And I would like to give this small story from one of my colleagues, with his permission of course, who is working in one of the remote part of Nepal, which is approximately situated more than approximately 3,000 meters from sea level. This place is called as Jumla, and he is Dr. Ramesh with his OR teammates, including the obstetricians. And this is a small hospital which is situated in Jumla. On one fine evening, he got a call from a labor room that patient had suddenly collapsed after delivery. He immediately rushed to the labor room, and what he found was that the obstetrician was doing bimanual compression, and the pediatrician and the anesthesia assistant was doing bag and mask ventilation, and 2 of the nurses were squeezing the IV fluids. And immediately he assessed the patient, and what he found was the patient was gasping, there was no peripheral pulse, pale, and only he could feel was carotid pulse. They suspected uterine rupture, and it was planned to re-explore. So with the help of the anesthesia assistant, the patient trachea was intubated immediately. There was no blood arranged. He requested the hospital administration to arrange for the bloods, and luckily his blood matched to the patient's own blood. And while the patient was being shifted to the OR, in the meantime he donated his own blood. And once the surgeon they explored, they found that it was a case of uterine rupture. They did subtotal hysterectomy, and they closed the abdomen, and the moment they did vaginal toileting, there was profuse bleeding. So the surgeon, they judged that it needs to be re-explored again, and when they re-explored, there were bleeders that could be identified, but still there were blood oozing out. And the surgeon was helpless. He tried to do the internal iliac artery ligations, but because of large, huge hematoma, he failed. And the last resort he could do was just pack the abdomen and vagina for some time. They waited for a few minutes, half an hour, and once the bleeders were stopped, they closed the abdomen with vaginal pack, and they shifted the patient to the ward with bag and mask ventilations. And with 5 hours of struggle, the patient had almost received 25 units of crystalloids, 2 units of colloid, and 9 units of blood. And after a few hours, patient self-extubated and was discharged on 7th POD. Now, I assume there may be several questions going on in the audience that probably some technique or some drugs could have improvised or better help these patients. I wouldn't like to go into discuss that part, but see the rather positive signs from this case. There was a well-trained anesthesiologist who was available, teamwork had helped, and we need to see the role of anesthesiologist beyond OR. But definitely there are certain limitations. There was no blood bank available in that hospital. As the patient was shifted in the ward with bag and mask ventilation, there was no intensive care unit. And the bigger question is, what if this patient had a home delivery situated in this part of Nepal? Now my outline of presentation I shall be focusing on 3 areas. The maternal mortality, where do we stand? Because it reflects the country's health and socioeconomic development, and what are the barriers, why there's high rates of maternal mortality, what are those barriers and how to overcome these barriers. Now these are certain facts from WHO 2015, and it's quite disturbing because there's approximately 300,000 maternal deaths, which is equivalent to 861 deaths per day, and that is related to approximately, which is every hour there's almost 36 deaths occurring, and more than 90% of these deaths occur in developing world. Apart from that, 1 out of 4 babies worldwide are delivered without skilled care. As a result of this, a Millennium Development Goal was achieved in 2000, where almost 187 countries participated, where 147 held the state of head were, they signed the Millennium Development Goals, and one of the target was to improve the maternal health. And this wouldn't be possible with collaboration between the developed and the developing countries. Now, have we achieved that target? Let us see those goals. From 2000 to 2013, there's dramatic reduce in maternal mortality rate, as well as the births that has been attended by skilled health professionals has been increased from 1990, and it has reached to almost 71% in 2014. But what about our country, Nepal? Has it achieved that target? If you see the MMR, when it was in 1990, it was almost 900, and 2000 it was pretty much close to 500. And as of 2015, the current MMR is 258, which means that from 2000 to 2015, there is only 51% reduction in MMR. And the goal set by the Millennium Development Goal was to reduce the MMR by 75%. And apart from MMR, other facts and figures from Nepal are also very disappointing, because only 60% of these women receive any antenatal health care from skilled provider, and less than 50% of these births are assisted by skilled provider, who are doctors, nurses, or midwives. And if we compare our MMR rates with the neighboring countries, it's very high compared to the neighbor countries. Now, my second question was, we need to identify these barriers. Now, if you see the pictures, these kids are moving from one side of the hill to the other side and going to the school. The first question would be, what really motivates them to go to the school? Who encourages them to go to the school? And that can be explained by the first barrier, that is delay in deciding to seek care. The second is, are they able to reach to the school on time? Are there any obstacles while reaching to the school? This can be explained by the delay in reaching healthcare facilities. And even if they reach the school to the other side, are they receiving quality education or not? And this reflects getting effective care, healthcare. Now, let us individualize and see those barriers pertinent to Nepal. If you see the picture on the left side, there's a teen lady who is sitting in a small hut. And this is a picture from a far western part of Nepal. And traditionally, it is believed that during the menstrual period, these women are being isolated from the house and they stay in a small hut, because it has been believed that they contaminate household and because of fear of God. And although this act has been criminalized in Nepal, it is still been practiced in far west of Nepal. And this is just an example of how women are being discriminated in our part of the world. And if a woman wants to seek obstetric health care, the decision is usually made by the woman's husband or other relatives. The other reasons are, if some complications occur during the childbirth, it is considered usually as because of evil, and they seek for spiritual faith healers. They go to the faith healers to seek the remedies. And there was a small survey which was done in the remote part of Nepal, why the women, they don't go to seek the health, or go to the health system to get delivery. And what they answered was, first, most of them couldn't afford going there. there was negative association related with CS sections, and a few of them said that while going to the nearby health, most of the women would deliver during those transportation. So this is another example of this woman who was in labor. She had almost walked for 2 hours to reach the nearby health post, but unfortunately she couldn't walk because of severe labor pain. And luckily, one of the general practitioner who was on the way to a remote surgical camp found this woman lying on the roadside, and he immediately assessed the woman, and he found that her cervix was fully dilated and was about to deliver. And he took a wise decision, and rather taking the woman to the nearby health post, he planned to deliver the roadside. And he made the arrangements, including for the neonatal resuscitation kit. And luckily, the woman delivered a healthy male child. And what it does reflect is that almost 11 to 14% of these deaths, maternal deaths, they occur during transfer to healthcare facilities. So we need to understand the delay, the second delay, that reaching to the health post. If you see the area of Nepal, it is half of that of Germany in square kilometers. But there's a huge diversity in terms of its geography, because it ranges from 50 meters from sea level to around 1,500 to 3,000 meters up to 8,000 meters. And these mountains and hills, they contribute approximately 75% of Nepal's land area. And only 1/3 of this population lives in urban areas. So because of this difficult terrain, you need to have a good transportation. It's a lifeline to have a good access to the healthcare. Unfortunately, less than 50% of the populations have access to all weather roads. 60% of the network is concentrated in lowland areas, and this is further worsened by frequent raining, landslides, and the only means of having transportations in the remote or in the highlanders are with the help of animals. And where there is no links, road links, the only way option is the aviation. Unfortunately, because of the bad weather or expensive, this is another limitations. And there are other means like ropeways, manual aerial lift are other options. And when all these measures fail, the only way to carry these sick people is in the stretchers. The third delay, which is very vital, which is the backbone of all these three delays, is to have a good health system. And to understand the Nepal health organogram, the primary care is being provided by the district hospitals and the community-based hospitals, whereas secondary and tertiary hospitals, tertiary care are being provided by zonal, regional, and central hospitals. There are around 75 districts in Nepal, and only 65 of these have district hospitals, and out of these 65, 1/3 only provide emergency obstetric surgery cases. Because of this, the government of Nepal introduced Safe Motherhood program in 2006, which encouraged these skilled birth attendants to increase the numbers. And in 2008-09, they improvised the birth preparedness package in all 75 districts of Nepal. And to attract this woman to go to the health system, to the healthcare, they provided incentives and free delivery care system. As a result of which, a survey which was been conducted in 2016 showed significant improvement in ANC, which has been provided by health professionals, which rise up to 84%, and there was decline in those number of percentages who had delivery at home, and institutional deliveries were increased. But again, there was a huge discrepancy if you have to compare between the urban and the rural areas, because 88% of this urban mother received ANC from skilled providers, whereas only 55 of them received in rural areas. Likewise, only 1/3 of this birth was assisted by the help of doctors. The other indicator to look into the health indicator is the CS rate, because it is a life-saving procedure. And according to WHO 2014 report, in Nepal, the rate of CS section is 5%, and 88% of these are emergency CS, whereas only 12%. But there's a huge gap if you have to compare between the urban area and the rural areas. What does this reflect is, in Nepal, still there's lack of sufficient doctors. If you compare with the neighboring countries, the distribution of doctors per thousand population is only 0.04% as compared to other neighbor countries. Likewise, there is a huge gap between those who are working in the public sector as compared to the private sectors. Approximately 13% of these doctors are working in public sectors. Why is it important is because if you see globally the cause of maternal mortality, the hemorrhage still holds the #1 position. And there's only decline in 16% from 2005 to 2015. But the story is different in the developed part of the world. Like in the US, the traditional causes of MMR has been declining, and other maternal-related comorbid conditions like cardiac conditions are in rise. And anesthesia-related mortality is very low. And this is no surprise, and similar in UK, which has been highlighted in the morning session. The anesthesia-related deaths in 2006 and 2008 were pretty constant, around 7. And the recent audit, which was been updated in 2014 to 2014, found that the number of anesthesia-related deaths were almost 2 or 3. But if you see, this contradicts the findings from low-income countries, the anesthesia-related deaths, because it's very high as compared to developed world. There's 1.2 deaths per 1,000 obstetric surgeries being performed, and it contributes around 2.8% of all maternal deaths, and almost 14% of these deaths are associated with CS sections. And general anesthesia, there's 3 odds of having maternal deaths as compared to neuraxial anesthesia, and subgroup analysis showed that the risk of deaths from anesthesia was higher in rural area compared to the urban settings. Now, they further did a root cause analysis of these all 124 maternal deaths, and what they found was almost half of these deaths were resulted from airway complications, and 1/3 of this were related to substandard care. What does this reflect is, if you have a well-trained anesthesiologist, probably these complications could have been prevented or well managed. So to understand the current situation of anesthesiologists in Nepal, we just need to go back and see how anesthesia practice has been evolved in our country. It was in the year 1955, the Dr. Bhavani Bhakta Singh Pradhan was the first diploma holder who did his diploma from UK and was considered as the first anesthesiologist of Nepal. And in his early days, he used to practice open drop ether technique and also provide spinal anesthesia as indicated. And it was in the year 1960s, the inhalation agents that were available were chloroform ether and trichloroethylene. And the local anesthetic in those days that was used for spinal anesthesia was only procaine. This picture is a classical example of a woman who is undergoing CS section in those days by open ether technique in the maternity hospital. Now, between 1964 to 1984, only few doctors went abroad for training in anesthesia, and half of them never returned to Nepal. So government realized that this program has to be introduced in Nepal itself. So with the help of University of Calgary in the capital university, a 1-year diploma in anesthesia program was introduced, and this was the beginning of development of health resources in terms of anesthesia in Nepal. Later, 1 decade later, this was upgraded to a 3-year program, and it was in the year 1999 in a hospital this MD program was introduced. And at present, there are roughly 35 residents who have been enrolled every year. And this is a vintage picture, the first 5 diploma holders who graduated from Nepal, along with their mentors, Professor Tom from Canada. But the bigger question is, do we have current sufficient anesthesiologists? In 1985, there were only 7 Nepali anesthesiologists for a population for 16 million people. Currently, there are actively 250 anesthesiologists who have been practicing in Nepal, which is approximately equivalent to 1 in 100,000 populations. Unfortunately, there's a huge gap because majority of them, they work in cities and only 10% they work in zonal or district hospital. So the government of Nepal realized that this gap has to be filled, and they promoted 1-year program to train non-doctors anesthesia providers so that they would provide anesthesia care at district level hospital. And currently 14 to 20 participants are trained every year, and as for 2012 data, there are 46 anesthesia assistants who are working all over the Nepal. But the vital question is, there is no society who is looking after them, and it's very important to maintain their competencies. And this NGO, Nick Simon Institute, conducted a program that is a distant blended learning course in which 22 anesthesia assistants participated, and it was also a mentor, educational support, and tablets were used as a primary educational platform. And what they found was they compared the scores before the education and after the post score, and there was significant improvement in those scores. And they reported that they found pediatric and obstetric surgical cases to be the difficult. And this was continued as a project which was published in Anesthesia in 2017. They were asked to document all these case reports in a tablet form, where 14 non-doctors anesthesia providers were enrolled, working across different hospitals, zonal and district hospital across Nepal. Apart from the cases, they were asked to document the pre-anesthetic assessment, ASA grading, type of cases anesthesia have been given, monitors and complications and outcome associated with the cases. There were approximately 4,000 cases that were logged in, and majority of these were cesarean sections, and 99% of these were performed under spinal anesthesia. There were minor complications as reported by this anesthesia assistant. There were 4 deaths been reported. 1 was because of eclampsia, and 3 deaths were because of multi-organ failure due to sepsis. Unfortunately and surprisingly, there were no anesthesia-related deaths. Now, we need to look into the world literature on non-doctor anesthesiologists. And this was a survey which was conducted in 2000, which found that of 200 countries, 107 countries are using non-doctors to administer anesthesia. And in 1996, the survey showed that in USA, almost 70% of the rural populations, the anesthesia had been provided by nurse anesthesiologists. And if I'm not wrong, in Netherlands, the practice is 1-on-1 or 2-in-1 system. And over the last decade, there has been a lot of debate going on, are these non-doctors anesthesia providers safe enough to provide anesthesia? So the objective was to assess the safety and efficacy of these different anesthesia providers for patients undergoing surgical procedures. And the 6 studies were included, 5 of which were large retrospective study, and there was no definite answers. But contrary to this finding, a current systematic review showed that the maternal deaths were higher when the anesthesia was given by non-doctor provider. This was doubled, the risk was doubled. And this may reflect many other several complexities, because perioperative risk, the anesthesia, it may be due to anesthesia, it may be due to surgery, and patient disease as well. And one of the contributing factors for anesthesia is vital important is standard monitoring. And the survey in 1990 across the 7 general hospitals where these diploma holders were practicing, there were no ECG monitoring, no pulse oximetry, no capnography. Only there was available was manual blood pressure monitoring. And a recent survey which was been held in 2015, where 98% had used pulse oximetry, only 89% had used blood pressure measuring, 2/3 had used ECG and the use of capnography was negligible. Now, the Lancet Commission had focused on the safe anesthesia, and because 5 out of 7 patients worldwide do not receive safe anesthesia. And the anesthesia-related factors may be because of lack of trained staff, lack of basic equipment, inexpensive drugs. And so to strengthen the anesthesia force in low-income countries, we need to increase the number of anesthesia providers. We need to continue to maintain their competencies. Incentives needs to be provided to retain these anesthesia providers. And it's very important to have interprofessional skills. And this is an example, classical example of this. And so there's a target which has been focused for 2030, and it's hardly 12 years from now. And the target is to have at least 80% of essential surgery and anesthesia service per country, and at least 20 surgical anesthesia and obstetric physicians per 100,000 of populations. And we need to applaud WSA for doing a terrific job along with its collaborators. So to sum up my presentation, Nepal is one of the countries which has high mortality rate, and majority of these deaths can be preventable. But again, there's lack of trained, appropriately distributed these anesthesia providers. The government of Nepal plays a crucial role in this. Lastly, efforts are to be needed to provide safe obstetric anesthesia by improving infrastructure, resource, and training, because education is the heart of the matter. Thank you.